2, 1. Good morning. I'm Dr. Eva Perusquia from Mexico, internist. It's my pleasure being with you this day for talk about a very interesting topic as is the obesity treatment. Today we're going to be talking about transcranial stimulation by direct current for obesity treatment. This is part of my curriculum and I have no disclosures with this theme. As we know, obesity is a worldwide disease, and at least in my country, 7 or 8 of every 10 adults have overweight or have obesity. And the future is not very promising because the forecast is that for 2045, almost 51% of the population will be overweight or will have obesity. When we talk about obesity, we know that we are talking of a multifactorial disease because we know that there are many different factors that can interact for this disease, for example, genetical, environmental, behavioral, etc. But when we talk about treatment, the World Health Organization established that the basic treatment must be caloric restriction and physical activity. One of the problems with this is that at least in my country and in all Latin America, 68% of the people abandon this treatment and don't continue with any diet in less than a year. We know that there are new studies trying to get better diets. For example, trying with intermittent fasting, low caloric protein balanced diets, ketogenic diets. But by now, anything has worked with all the people, or not everyone can afford all kind of diets. Talking about transcranial stimulation, it's recognizing that diabetes is multifactorial, and we must be aware that it's talking about neuroconductual food intake, but also biological, environmental, conductual impact. And if we can figure out how is the reward response system in the brain, how it could be managed to change conducts and cognition for the self-regulation of feeding behavior, we will be able to change or impact really the future of the obesity. Talking about physiological basis of food intake, we must recognize that for the hunger control, there are two main areas in our brain who interact one to each other so that they can balance satiety and hunger. When we talk only about the cortex, there are three main areas, the prefrontal, parietal, and cingulate cortex, that interact one to each other, so that we know, for example, that when lateral prefrontal cortex is more active, we can get more weight loss and its maintenance. The other part of our brain that is very important for control hunger and satiety, we know that is the hypothalamus. In the different hypothalamic nucleus, we can find a mixed interaction between these different nucleus, so that the lateral hypothalamic area control hunger and the usage of body's reserves. And the ventromedial nucleus, they can control satiety as well as the storage and conservation of body reserves. In this way, lateral and ventromedial nucleus can interact so that we can have this balance between hunger and satiety. Also, we know that it's not only the main control in the brain, but also there's interaction with other organs in our body. For example, adipose tissue, bowel, pancreas, and there are many different substances and hormones interacting for gaining again this balance between hunger and satiety. There are many different studies, first mainly with ghrelin and leptin, but also with all the other substances and hormones that can interact for the gain or the loss of the weight. So now we know that for maintain our weight is not only the balance between caloric intake and energy expenditure. We know now that also is the hormonal regulation or deregulation, but also the communication between our all the areas in our cortex and limbic system. We know now, thanks to the neuroimaging exams or tests, that in the obese patients, we have an imbalance between the prefrontal and the dorsolateral circuits. It's like a exchange between go and stop circuits, and this imbalance in the overweight or the obese patients, we can recognize it in neuroimaging studies. The problem is that we can't do neuroimaging studies for all the people or in general population. Okay, so talking about transcranial stimulation by direct current, is talking about the use of this kind of current as a non-invasive and most of all not painful therapeutic tool. We know that through this therapy we can regulate cortical excitability and control the behavior, and we can induce permanent functional changes in the brain so that we can make new synapses and we can induce brain plasticity. And one of the best parts of this kind of therapy is that it can be used in general population to modify eating behavior patterns. So I'm presenting you a study we did a couple of years ago, and our objective was to evaluate the effect of transcranial direct current in obese patients undergoing different nutritional therapies. This was a double-blind clinical essay did between January 2017 and December 2018. The obese patients were selected by non-probabilistic sample recruited by invitation in the social media from the clinic, the Neurosciences unit. We include both genders between 18 and 55 years old, and with a body mass index above 30 as definition of obesity. Also, we get an informed consent of all of them. We have some exclusion criteria, and I want you to notice that one of the main exclusion criteria were the history of epilepsy, neuropsychiatry, diagnosis disease, or that the patient were in treatment for any mood disorder or a psychiatry disorder. Also, if they had other concomitant or chronic diseases that can interact or disbalance the hormones that we recognize as important for obesity. There were some elimination criterion, for example, adverse reaction to proteinic diet or to neurostimulation, mainly a skin reaction to the stimulation, or if they started with some concomitant diseases that needed treatment. At the beginning of the study, we did basal measures with all those parameters, including body composition with bioelectric impedance, general labs, and a survey about food preferences. And we count with the participation of the medicine faculty of Universidad Nacional Autónoma de México. Also, at the beginning, we did a quantitative electroencephalogram. It was performed with this equipment with all the international standards of quality that were needed for this kind of studies. And after this, we did an aleatory distribution of the patients in 3 groups. In the first group, it was a very low calorie diet, only for the first 12 weeks, between 600 and 800 calories, and with balanced proteins with 0.8 to 1.2 grams per kilogram. Also, they have supplementation with micronutrients, physical activity, psycho-emotional accompaniment, and after the 12th week, we migrate them to a hypocaloric diet, about 1,000 to 1,500 kilograms per day. In the second group, it was a low-calorie diet, calculated with the basal energy expenditure less than 20%, and with this distribution for the protein, carbohydrates, and lipids. Also, the other supplementation was exactly the same. And after the 12th week, we did a new calculus for the an uncalculated diet, hypocaloric diet with the new basal energy expenditure. The third group was exactly the same as before, with the same distribution of the carbohydrates, but the difference was in the kind of neurostimulation they were receiving. Because, as you can check in this chart, the group 1 and 2 received active neurostimulation. They were 20 sessions 2 or 3 times a week, with the anode in the left prefrontal cortex and the cathode in the right supraorbitary cortex. And the group 3, they receive only what we call CHAM method. This is a mild electric pulses only for 1 minute, and after that only they receive simulated neurostimulation. That means that they were not really receiving any neurostimulation, only the diet and all the supplementation, okay? And the follow-up for the 3 groups was as follows. Every 2 weeks, we did a clinical exam and the review of the daily food diary. Every month, both composition analysis and labs only as needed. And at the end of the protocol, in the week 14, we did a whole clinical exam, body composition analysis, lab test, and a new quantitative electroencephalogram, and the review of the dairy food preferences survey also. Okay, our results showed that from the 90 patients that were selected, only 50 complete the program. From these 50 patients, 51.4% were female. All were in the ages between 42.6 plus less 9.3 years. The starting weight now in average was 95.8. The height and the body mass index it was the 36.7 kilograms per square meter. 63.5% of our patients were right-handed. In this chart, we can show you all the parameters in the three groups. The distribution was similar in the three of them. Only the third group has 20 patients. The other ones had 15. The weight, abdominal perimeter, muscle mass, everything was very similar between the different groups. And here we can check the loss of weight, the changes in the body mass index, and the abdominal perimeter as indirect sign of fat, abdominal fat. And we can check here that the group with the protein diet and neurostimulation had the highest loss of weight, as well as the highest modification in the other parameters, body fat, abdominal perimeter, and body mass index. And the third group that was with diet but without neurostimulation, they had the less degree of change in the different parameters. Also, here, when after we did the first quantitative electroencephalogram, we noticed that 82% of our obese patients had a very diminished ratio theta beta. We're going to talk about this a little bit after. And here we can notice that in the group 1, this ratio was very diminished in the 76% of our patients. In the group 2, it was 92%, and in the group 3, 78%. Only 15% of our obese patients had a normal theta beta radio, and 15.3% had elevated, high or very high radio theta beta. After the stimulation, these parameters changed, and in the group 1, 53.8% of the patients had very diminished radio. In the group 2, only 23.1% had very diminished radio, and in the group 3, only 78.9% had very diminished radio. That means that without cranial stimulation, the radio barely changed, and with the stimulation, it changed most of all in the first group. Most of all in the second group, sorry. Okay, talking about Roseman areas, before the neurostimulation, we noticed that there were some areas more active, for example, 3, 7, 19, 18, and 9. You can see here that most of these areas are in the frontal and occipital lobes. And after stimulation, the areas that were more active were 40, 5, 8, and 31. These areas mainly located in the parietotemporal lobes. Okay, which is the analysis of all these results? First of all, the weight loss was greater in the group 1. I mean, the one with the protein diet. And we know that in part this is because of the anorexigenic effect of the protein diet that favors biochemical balance. As seen before in neuroimaging studies, we confirm that the highest right-handedness laterality increased left hemispheric activity, and the higher neuroplasticity was seen with neurostimulation. That means that neuronutrition is important for a better cognitive and emotional cerebral functions, but it is not enough for modifying neuronal structure. I mean, for having more synapses and for having cerebral plasticity. We need the neurostimulation and not only the correct nutrition for our synapses. When we did the quantitative electroencephalogram, we noticed that the radio theta beta waves were different in the obese patients than in the non-obese patients. What is this? Oh, okay. The brain waves balance, it is noticed in the electroencephalogram in these different patients because when we have excessive theta waves, we have less brain plasticity and a delay in the bioelectric maturity. And also we have more psychoaffective problems. And in the other side, when we have excessive beta waves, we have more mood disorders, anxiety, insomnia, and obsessive compulsive behavior. In our patients, we confirm, as we saw in, in other studies, that the obese patients have more mood disorders, and this is shown with the disbalance theta beta ratio waves. So after neurostimulation, we notice that all the groups change when they have neurostimulation, but the third group didn't change. That means that in these groups that they had more mood disorders, we, with the neurostimulation, impact in changing this kind of imbalance. And in the third group, there were any changes. When we analyze the Brodmann areas, we said that before the neurostimulation, we have these areas with hyperexcitability. What does this mean? That this patient have a more affection, not affection, they have more diseases related or problems related with planning, willingness, memory, mainly visual memory experiences, and the interact of these visual areas with limbic circuits. And after neurostimulation, we noticed that the areas that were more active and in better balance were those related with attention, math processing, memory, short-term memory, those known as executive activities, also areas for planning and control movements. They were more active with a better relation with the limbic circuit for processing emotions and recognition of with mental recreation of different situations related also with movement and memory. What does that mean? That means that the key point for the conduct control, and not only for food intake, is changing the automatic responses without planning, without willingness for aware processing of perceptions, where the patient can decide, plan, get goals, and recreate in his mind how is the way he wants to act, and not only having impulsive conductual behavior. Our conclusions for ending this presentation are that the transcranial stimulation increases cognitive control and decreases the food reward mechanism. Also increases plasticity in our brain, promoting cognitive and emotional functions for a brief period. But if we can continue the stimulation, these changes can turn into permanent changes. And also, if we use pharmacological therapy for biochemical control of mood disorders or impulsive conducts, the impact in these patients would be more significant. Also, the impact in the quality of life, improving executive functions and emotional controls, goes more than only food intake, because it can give the patient more decision-making progress for solution problem, for setting and getting goals, for project completion, and also for improve the frustration to tolerance, that in these patients with obesity is so important. So thank you very much for your time and your attention. By now, I'm not working directly with the Neurosciences clinic, but if you have any question, please don't hesitate to send me an email, and we can contact you for answer all your questions. Thank you very much, and bye-bye.